Welcome to the Deep Dive, where we take a stack of dense sources, pull out the critical nuggets, and give you the shortcut to being truly well-informed.
Today we're tackling a really important public health topic, one that doesn't always get the attention it deserves.
That's right. We're talking about osteoporosis screening and, more specifically, the science behind preventing these really devastating fractures.
And our central source for this is one of the most authoritative voices in U.S. clinical practice, the U.S. Preventive Services Task Force, or the USPSTF.
We're looking at their latest recommendation statement.
And what we found, it really underscores just how high the stakes are when we talk about osteoporotic fractures.
Absolutely. The source material is brutally clear on this. This is not just about a bad break.
No, not at all.
We're talking about a whole cascade of severe consequences. Things like psychological distress, losing the ability to perform basic activities of daily living ADLs.
Which means a massive loss of independence.
A huge loss. And, critically, it leads to a subsequent, much higher risk of death. It turns what seems like a temporary injury into a life-altering event.
Exactly. And because those consequences are so severe, the need for timely, accurate prevention becomes just paramount.
So that sets our mission for this deep dive. We aren't just going to read you the guidelines.
No, we want to give you the blueprint behind them.
We're going to unpack the USPSTF's evidence assessment so you walk away knowing exactly who they recommend for screening, who they don't, and maybe most importantly, why.
To frame this right, we need to be clear on the population they were studying. Their systematic review looked at adults 40 years or older.
Okay, 40 plus.
But with two key exclusions: no known prior diagnosis of osteoporosis and no history of fragility fractures.
So they were really studying primary prevention.
Yes, screening people before the problem becomes obvious.
And that's a key distinction, right? Because it means they're looking for broad, efficient public health strategies, not, individual treatments.
That's it. The whole objectives was to weigh the benefits of mass screening against the potential harms in this very broad adult population.
This is where we get into that very specific language of clinical guidelines.
Mm-hmm.
The USPSTF doesn't just say yes or no.
No, they quantify their confidence. They use terms like net benefit and certainty.
Right. So for a recommendation to be strong, they have to find that the net benefit, the good minus the bad, is significant.
And they have to be highly certain of that finding.
Let's zoom in on that net benefit for a second. If we're talking about screening millions of people, there have to be costs and harms involved. It's not just a free X-ray.
That's a fantastic point. Screening is never risk-free.
So what were they weighing?
Well, you have the potential harms, like the cost of the DEXA scan itself, the minor radiation exposure.
Okay.
But more significantly, you have the potential for false positives that can lead to a lot of patient anxiety, maybe unnecessary follow-up tests.
And then if someone gets put on treatment.
Right. Then you have to factor in the potential side effects of the medications, some of which can be quite serious. They have to prove that the population benefits. So fewer broken hips, fewer deaths, significantly outweigh all of those cumulative harms.
Wow. It sounds like a really high bar for evidence.
It is.
So when they applied that rigorous standard, where did the evidence actually, come together most clearly?
The evidence was clearest and strongest when it came to women. They were able to establish a very high degree of confidence for certain female populations.
Okay, so let's get into the specifics for women, because this is where those actionable age thresholds come in.
This is what they call a B recommendation. The USPSTF concluded there was a moderate net benefit based on moderate certainty of the evidence.
A-B recommendation being a strong signal for doctors to adopt this in clinical practice.
Correct. And the first group is the most straightforward.
Where's that?
All women 65 years or older.
So a clear line in the sand, you hit 65, you get screened.
Exactly. Age alone is the driver. At that threshold, the cumulative risk of a fracture is high enough that it outweighs the harms of screening.
But there was a second group of women, right? One that was a bit more nuanced.
Yes. The second group is postmenopausal women who are younger than 65.
And for them, the recommendation is conditional.
It's conditional. They also receive that B recommendation, but with a really crucial asterisk. Screening is only recommended if they are at an increased risk for an osteoporotic fracture.
This is the critical distinction we want you to grasp. For the 65-plus group, age is the determinant.
Right.
For this younger postmenopausal group, it's all about a clinical risk assessment. So what does that assessment actually look like? How is increased risk defined?
Well, clinicians aren't just guessing. They use established risk prediction tools. The most common one mentioned in the literature is the fracture risk assessment tool, or FRAX.
FRAX. Okay, so what does FRAX look at? Things like smoking history, family history, low
Yeah.
BMI.
Exactly those things. It looks at parental history of a hip fracture, current smoking, long-term use of oral steroids, rheumatoid arthritis, low body weight. It's a whole synthesis of risk factors.
And that tool calculates what, a percentage chance of a fracture?
It calculates a 10-year probability of having a major osteoporotic fracture. Essentially, it identifies the younger women whose overall risk profile is similar to that of an average 65-year-old woman.
I see. So it connects back to that first recommendation. The tool provides the objective evidence needed to say, okay, for this person, even though she's younger, the benefit of screening is high enough.
Precisely. It all comes back to that net benefit calculation. If your risk is low, the potential harms of screening and treatment might tip the balance. But once those risk factors stack up, the benefits of prevention clearly pull ahead.
That level of certainty they achieve for women is, well, it's impressive. Moderate certainty of a moderate net benefit.
It is.
But now we have to turn to the other half of the population. And this is where it gets really interesting. What did the USPSTF find for men? I mean, we often think of this as a women's health issue, but men certainly break bones.
They absolutely do. But when the task force applied that same rigorous review process to men 40 and older, they landed on something called an I statement.
I4.
Insufficient evidence.
Insufficient evidence. Now, I think a lot of people might hear that and interpret it as a no, a recommendation against screening, but that's not what it means, is it?
Absolutely not, and that's such a critical point. An I statement is not a no, it indicates an evidence gap. The USPSTF is essentially saying, based on the current research, we don't know if the benefits of screening men outweigh the harms, that evidence just isn't there to make a call one way or the other.
So why the gap? Why do we have this moderate certainty for women and basically a big question mark for men?
Well, there are a few key reasons. Historically, osteoporosis research and all the big screening trials have heavily focused on postmenopausal women.
Because the mechanism, the drop in estrogen, is more uniform and predictable.
Exactly. For men, it's more complicated. When men develop osteoporosis, it's often due to secondary causes.
What do you mean by secondary causes?
Things like long-term steroid use, certain chronic diseases, low testosterone. It's not just the age-related bone loss in the same way.
And since the USPSTF was focused on primary prevention in the general population,
They just didn't find enough data. Because male osteoporosis often has a known secondary trigger, many of the men who would benefit from screening are hopefully already being monitored for that underlying condition.
so the large population-level primary prevention trials just haven't been done for men.
Not with the same scale or focus as they have for women. So this I statement, this lack of a recommendation, it really highlights a genuine scientific deficit. It means that screening for men, when it's done, is driven by individual clinical judgment based on those secondary risks, not a universal evidence-based guideline.
The absence of a recommendation is itself a key piece of information.
It's a huge piece of information. It signals exactly where the research needs to go next.
Okay, let's connect all these dots for you. We started with the severe stakes loss of independence, increased mortality risk, which is what makes this whole topic so urgent.
And now we have the official roadmap from the USPSTF, a roadmap with, I'd say, 3 distinct zones.
Right. First, the zone of certainty. That's the clear B-level guideline for all women 65 and older.
Then you have the zone of conditional action. That's the B-level guideline for younger postmenopausal women, but it's contingent on using a risk assessment tool like FRAX.
And third, this striking evidence gap, the I statement for men, which tells us that while the risk is real, the evidence just isn't there yet to support a universal screening policy.
And having this knowledge is what truly empowers you. You now understand the precise thresholds, that age of 65, the need for risk stratification in the younger group, and the context that governs these decisions.
It moves you beyond just a general awareness to actual clinical literacy.
Yes. And it all comes back to preventing those severe consequences we talked about at the start. That's the urgency behind every one of these guidelines.
So to just quickly recap the technical distinction here.
For women, specific groups get a B recommendation. That means there is moderate certainty of a moderate net benefit.
And for men.
For men, the I statement means there is insufficient evidence to determine if the benefits outweigh the harms at a population level.
It's that differentiation in the language of evidence that's so illuminating. They achieve moderate certainty for women, which was enough to issue a strong recommendation. But for men, they couldn't even reach a low certainty. They just declared the data insufficient. So here's the final thought for you to take away. What does this distinction between achieving moderate certainty on one hand and declaring insufficient evidence on the other tell you about how medical guidelines are built? And maybe more importantly, how much weight should we place on the current evidence gaps in our medical literature? It shows that the scientific process itself creates these areas of uncertainty, and dealing with that uncertainty is often the very first step toward discovery.